So welcome everybody to the latest instalment of this Royal College of Surgeons of Edinburgh webinars. This afternoon we're lucky enough to have Mr. Richard Guy, who was a former colleague and mentor of mine here in Oxford before taking up a clinical lead in emergency surgery up at the Wirral University Teaching Hospital. Richard is a colorectal surgeon with an interest in emergency surgery, and obviously is the current clinical lead up in the Wirral. And today's going to be talking about the overview of the management of acute diverticular disease. Just before he kicks off, I would just like to remind you all that the next seminar on the 7th of May is the Principles of Stoma Formation and Management, and that's by another one of my colleagues, Mr. Stephen Boyce, who's also a fantastic speaker. But for now, I'm going to hand you over to Mr. Guy for a short presentation on the management of acute diverticular disease. Thanks, Richard.
Great, thank you, Giles. I'll extend my thank yous to the Royal College of Surgeons of Edinburgh and to Abby, who's coordinating this session, as well as Mike Silver, who's had an awful lot to do with these webinars. And it gives me pleasure to discuss the management of acute diverticular disease, which I'm sure you've all managed in some form or another. Well done for joining on such a lovely lockdown day. So I'll talk for about 20 minutes. We'll have 10 minutes of questions perhaps. So let's kick off. I'll make it as relevant as possible in terms of cases, and all the cases that I'll present are cases I've dealt with myself. Here is a lady a few years ago who presented, as they often do, on an emergency take with abdominal pain and the usual kind of comorbidities, it would seem, with obesity, some lung disease. She was a long-term smoker and a history of depression for which she was taking medication. And on examination, she had abdominal tenderness, particularly in the left iliac fossa where there was peritonism. And there was a suspicion of diverticulitis. And she went on to have a CT scan. And just to cut to the chase, she had an emergency operation. Now, this was perhaps 10 or 15 years ago, and things have moved on a little bit. But have a look at what happened to her. Here is her CT scan. And if you can see my arrow, this is an axial section here. Here is the diverticular abscess. You can see pockets of gas within it. There is an acutely inflamed diverticular segment in the sigmoid colon. And here's the coronal section showing the same thing. Here's the rectum, and here is a big pelvic abscess. She went ahead and had an operation. And we'll discuss perhaps in a while whether this was the right thing to do, but she had what's a not uncommon complication. She had a Hartmann's operation, and 5 days later, this is what the colostomy looked like. It's clearly plum-coloured. It's not looking very happy. The wound is looking a bit mucky, and there's clearly something amiss here. A few days later, she burst her abdomen. She had an abdominal dehiscence, and you can see the consequences of that with superadded infection, with pseudomonas, various other wounds that have been used to salvage the situation, and an open abdomen for which the outcome is very often poor indeed. And she had further surgery and went on after about 6 to 8 weeks or so to develop an intracutaneous fistula. Owing to the exposed loops of bowel there, and all the consequences of that complication with months and months in hospital, a reconstructive operation, and so on. And she died in the end. And one has to go back to these cases and ask, well, could we have done better in this situation? That's really what I'm going to try to discuss today. Some of the options that we have at our fingertips, perhaps that can lead to a better outcome than I've shown. I'm not going to spend too long on the anatomy and physiology and all the stuff that is very familiar to you, I'm sure, and we're going to talk more about the management. But suffice to say that here is diverticulosis. Here's a diagram on the left showing the diverticulum, which tend to come out, don't they, between the longitudinal muscle, that's the tinea coli, and you can see a photographic section of a resected specimen with the multiple diverticula there. And of course, they perforate, and it's the perforating mechanism that creates the complications associated with diverticulitis. Here's an endoscopic appearance, and you can see that here's a case, looks like a Swiss cheese, doesn't it, with multiple potential holes. And these are the diverticulum basically is mucosa and submucosa with no muscle, and so they're prone to perforation. Most cases in the West are associated with diverticulosis of the left colon, particularly the sigmoid colon. But don't forget that diverticular disease can affect the whole colon. And here's an endoscopic appearance in the right colon. You can see the ileocecal valve in the distance. And right-sided diverticulosis is more likely to occur in the Asian population, but they can bleed, and indeed they can become inflamed. So don't forget that it's not just a left-sided disease. So what's happening in a diverticulum? Well, there must be a complex interaction between these things you can see on the slide here, with undoubtedly genetic involvement, with defective immune regulation perhaps. Even the formation of the diverticulum may be genetically associated. There's an interaction with diet and lifestyle, and of course the microbiome that we talk about in association with most diseases these days, and certain medications which may predispose to diverticulosis and indeed diverticulitis. So what about the assessment? Well, the typical presentation is one of gradual onset of left iliac fossa pain, a bit of bloating, non-specific symptoms, maybe some bowel change, and maybe a history of previous episodes of the same sorts of symptoms. And we go on to examine, and we're looking for tachycardia, perhaps a fever, and tenderness particularly located in the left iliac fossa, or indeed the lower abdomen in the suprapubic region. And investigations. Well, we don't like to talk about routine investigations. All investigations have to have a reason, don't they? But we're looking for a leukocytosis, and the CRP can be very useful here to guide treatment. And a CRP, just to put in your heads a number, a CRP of 150 or more is more likely to be associated with complications, and a CRP of over 200 is more likely to be associated with post-operative complications if the patients need to go ahead and have surgery. And CT scanning now is the mainstay of both diagnosis and indeed planning treatment. And there's not much role for plain abdominal or plain chest films, except perhaps to look for pneumoperitoneum, but that's really about it. Do beware of the right-sided tenderness. The sigmoid loop can be quite floppy, and it can sit partly across in the right-hand side of the abdomen. So patients may present mimicking appendicitis, and indeed diverticulitis has been called by some left-sided appendicitis. Here's a case of mine from around 3 weeks ago, a gentleman who had right-sided abdominal pain and a palpable mass, and here in fact you can see a giant diverticulum, or possibly an old perforation that's become walled off. You can see this sigmoid loop of diverticular disease here, but mainly, the trouble is mainly on the right. So quite an interesting thing, just beware of that. And so imaging, as I've pointed out, is the gold standard, and we tend to do that early, really soon after presentation. And it acts as a guide, as I've said, and repeat imaging is very helpful once you've initiated treatment, just to see whether you're winning or whether the patient is radiologically becoming worse. And here is, again, you can appreciate the acute inflammation in this diverticular segment in the sigmoid colon. I don't expect to read all of this, but suffice to say that nowadays we're trying to manage as many patients outside the hospital environment, or at least on an ambulatory basis. And there's no doubt that there's a proportion of patients who may have diverticulosis, or at least mild diverticulitis who are systemically well, who may not require antibiotics or indeed can be sent home on antibiotics, provided there's some kind of safety mechanism by which they can be reviewed if necessary or indeed as planned. So not all patients need to come into hospital. I think that's important this day and age. Here's a representation of the disease behaviour. It gives a slightly false impression that there's a continuum from no diverticulosis through to complicated diverticulitis. And as I'll explain in a moment, that's by no means necessarily the case with all patients. But around 60% of Americans, and indeed the Western population in general, will develop diverticulosis. They won't necessarily become symptomatic, and indeed you can see a small proportion, less than 5%, go on to develop a bit of diverticulitis, and some develop complicated diverticulitis, 12% or so, and then some will go on to develop second and third episodes in the sort of proportions that you can see. This is a little bit oversimplified, as you'll come to appreciate. And indeed, only 3% of patients may have had a previous attack, but look at the subsequent data there. 60%, nearly 2/3 of patients having surgery have had no previous history. And 90% of patients who die with a perforation, in other words, the worst group, have had no previous history of diverticulitis. And so one might assume from this, for some patients, the first attack of diverticular disease may very well be their worst, and may not just be a progressive disease. Just the antibiotic discussion. This is one of the controversies. There is good randomized controlled trial data which concludes that in uncomplicated diverticulitis, that is just inflammation in the colon, you may not need to give antibiotics. And one has to do that very carefully and selectively. It may not be necessary in some more advanced cases, and I'll go on to explain what the Hinchey classification is, but this is more than just a bit of diverticulitis. So we might be able to push the boat out with avoiding antibiotics and indeed the side effects associated with them. We need to provide, if we're going to give antibiotics, of course, gram-negative and anaerobic cover. Surprisingly, there isn't any very good guidance on antibiotic administration in complicated cases. For example, the length of intravenous course, the length of oral antibiotics, and so on. It's often a best guess basis on which we base our treatments. So complicated diverticulitis then, which is the more severe form, and here is a definition: the acutely inflamed segment of diverticulitis giving rise to a phlegmon, that's an inflammatory mass, abscess, fistula, or perforation. And here is the Hinchey classification on the left, originally described in 1978 and modified more recently. So I'd concentrate on the right-hand side. There's your 0, which is your mild case we've talked about. And then it progressively, worse inflammation, an abscess that's confined, an abscess in the pelvis mostly in Hinchey 2, and Hinchey 3, the generalized peritonitis, and the worst case, which is the fecal peritonitis, which is the Hinchey 4. I will talk very briefly at the end about the fistula disease associated with diverticular disease. I won't talk about obstruction. That's a separate talk in itself. Suffice to say that stricturing is the result of multiple episodes of inflammation, and so it's one of the causes of large bowel obstruction. So Hinchey 2 and Hinchey 3 are the types associated with, if you like, the most controversy, and these are mostly what we see in practice. So what do we do about the pelvic abscesses? Here is a case, again, a case of mine. There is a big pelvic abscess. This is the bladder at the front, and you can see this is an axial section. Well, for drainage of an abscess here, you can see that the route in that's been taken is transgluteal. So the patient is now on their front, and there is the needle and the drain going in to drain that abscess. And in this situation, done very successfully, there's the patient flipped over with a subsequent CT. And you can see, compared to the first image, that the abscess has largely resolved, not completely, but it's prevented the patient having to go ahead and have an emergency operation. So abscesses are seen in association with diverticular disease in 15 to 40% of patients with the more complex disease. And you can see that maybe up to a fifth of patients are suitable for drainage, provided you've got a radiologist prepared to take this sort of case on. It allows about a quarter of patients to avoid emergency surgery, which is a good thing. You can take the heat out of the situation. And abscess size probably does matter. And anything over 3 centimeters or so that's not drained percutaneously is more likely to be associated with failure of disease control. And once you get to a size over 5 centimeters, you're much more likely to require surgery. And that's good evidence. And over half of patients with an abscess, such as I've shown, will eventually require surgery. It may not need to be done as an emergency, but ultimately, in due course, these patients very often go on to require surgery. Some abscesses, of course, I said radiologists, you need to have a friendly radiologist to whom you can go and explain the situation, but some are simply not accessible by a percutaneous route. Here is a coronal section. There's a woman who presented about a month ago onto my service. And one might look at that and say, well, there's a really ripe grapefruit-sized abscess. Surely we can get into that. Here's the axial section. But you'll notice that these are the iliac vessels. This is the front of the abdomen. And there's absolutely no way in there without going through the colon or through major vessels. And so we ended up having to operate, unfortunately, on her. And she did well, but she required a colostomy. And she was 75, and it's all a bit upsetting. So some cases we cannot drain by any other route. There's a certain group of patients, those with immunocompromise, those on steroids, those on other immunosuppressants, who really will not settle. And you need to be thinking about relatively early surgery for cases like this. Here's a man on long-term steroids who was in and out of hospital and always had an appearance on his CT like this. He just never got better and had to have a fairly miserable operation. But this is a special group. The immunocompromised group really don't settle with conservative measures. And so surgery for some is absolutely inevitable. We've seen that up to about a fifth of patients develop the complicated disease, and 10 to 20% of patients will go on to require surgery. And those who have surgery, a large proportion of them will have generalized or fecal peritonitis. These are the Hinchey 3 and 4 patients. And owing to the fact that this disease is mostly affecting the elderly, a large proportion will have comorbidities, which really do have a bearing on the surgery, the type of surgery, and indeed their outcomes. This is difficult. This is difficult decision-making to be made about a difficult group. And we now have NELA. I'm sure you're aware of the National Emergency Laparoscopic Audit, and a very, very handy tool, which is the perioperative risk calculator. POSSUM is not so useful in this situation. NELA is good. And we have to make these decisions, don't we? Is your conservative treatment working? Is the patient really getting better? Is surgery likely to be required? If it is, how am I going to do it? Is the patient fit enough? What are the risks? What's the outcome going to be? So let's just look at a couple of cases where that sort of decision-making would be very challenging. Just like the first case I showed you at the very start. Is an 84-year-old lady, you might say typical of the type that's presenting to an emergency general surgery service. She's 84, she has type 2 diabetes, she's hypertensive on the usual medication, and she's on Apixaban, aren't they all? Huge number of patients coming in on some form of anticoagulant really is the flavor of the day, and she's unwell. And here she is, coronal section again. She's got a perforating segment of diverticulosis. There is free gas. There's gas you can see on the axial section here within the iliacus muscle and the psoas muscle, and really inaccessible to percutaneous drainage, and a fairly horrific prospect for surgery. She died. Conservative treatment was pursued, and she didn't make it. That's the type of patient And there's her needle mortality risk of 22%, bearing in mind that anything over 5% mandates consultant surgeon, consultant anaesthetist, and a critical care bed. And this lady had a mortality risk of 22%, and she was turned down for surgery, and she succumbed. Here's something at the other end of the scale. It's not exclusive to older people, unfortunately, and we do see a lot of young people very often who have a particularly aggressive diverticular disease. This is a man who presented to us about 3 months ago. He was blind. He'd been an athlete, but he was blind through retinitis pigmentosa. He had bronchiectasis, and he had abdominal pain, the tachycardia, tender abdomen, a high CRP. You remember that figure of 200, which predicts a bad outcome if you have surgery, a high white count, and a CT showing perforating sigmoid diverticulitis, a particularly bad segment of sigmoid. What on earth do you do in this sort of situation? These are challenging cases. And in fact, in this situation, he was able to tolerate aggressive conservative treatment, and he left hospital after about a month, and he will go on and have an elective resection. But just consider how you manage a colostomy if you're blind. And these are the sorts of cases that are really not unusual on the emergency service these days. Very challenging decisions to be made. What about laparoscopic lavage, the keyhole operations to try to manage these difficult patients? Well, it's feasible. It's possible to do it. Some people are very skilled with minimally invasive surgery. And as with all new types of approaches, there was a lot of initial enthusiasm when laparoscopic lavage was first, if you like, brought onto the market a few years ago. And initial success was reported. I think we've kind of reassessed the whole thing now and realized that it's not really all it's cracked up to be. It might, in good hands, allow patients to cool off and avoid a resection. It's mostly reserved for the cases where you've got a pelvic abscess or indeed some generalized purulent peritonitis if you give a very, very good washout. But there are certain technical considerations. And if you look at the randomized controlled trials, you can see the numbers are relatively modest, but these are fairly well-controlled trials, which, if we cut to the chase, when you look at major postoperative complications, randomizing between just lavaging, just washing out versus resection, it comes out in favor of resection rather than lavage. And indeed, if you look at early reoperation, in other words, failure of the various techniques, it comes out in favor of resection. So there's been a rethink about the place of laparoscopic lavage. I think following that initial enthusiasm, it's become much more disappointing, and we're really moving away from that approach now. You can, of course, just bring a colostomy out and divert the fecal stream away from the problem with a colostomy or ileostomy. This might be something we might need to revisit in years to come, but there's only one randomized study which basically showed no great advantage. But what about if we combine it with that procedure of laparoscopic lavage and divert away from the scene of the trouble? That's a bit of an unknown, but something, it's just a bit of a food for thought, really. So let's talk about resection. Now, the most common operation that's still performed in the UK is a Hartmann's operation, and I'm sure you know what that is now. That's resection of the sigmoid colon that's diseased, raising an end colostomy and closing off the rectal stump, and a variable length of colon may be removed from just taking out the perforating segment itself, or indeed most of the left colon. Not a nice operation to do, and it is associated with complications, and it can be a little bit of a mess sometimes, particularly when it's done for fecal peritonitis. And you can understand that the complication rate may indeed be quite high for that. We don't like doing it because we don't like reversing the Hartmanns. We don't like to rejoin them back up again. And it's the question that's always asked by the patients: if I have a colostomy, can I get rid of it in due course? And the answer, we rather glibly say, is, well, yes, at some stage we will. But look at the complication rate of reversing the Hartmanns after several months, up to 50%, a leak rate up to about a third, mortality rate that's very measurable, and a non-reversal rate up to 50%. So we have to be careful about doing the Hartmann's operation, and we have to be very realistic with our patients, because many will not be rejoined and they may have to have a colostomy for the rest of their lives. So here is a very useful systematic review and meta-analysis from the States, 6 randomized trials, but goodness me, look, only 600 or so patients, on which the following can be based, really. And I think we accept this now, that there's an increased risk of major complications with the laparoscopic lavage approach. We've moved away from that, but resection, if you've got a Hinchey 3 or 4, resection is really mandatory now, we think. There's a high rate of complications after the Hartmann's resection, and the reversal rate is lower than we like to think, perhaps. And there are some patients in expert hands, perhaps, where the conditions are appropriate, where primary anastomosis could be recommended. If there's not much contamination, if the patient is otherwise well, and you have the tools at your disposal and the expertise to do so, then you may wish to join the patient primarily. In some cases, we will raise an upstream stoma above it just to rest it, but the conditions have to be absolutely perfect before you do that. So caution to be exercised. We talked about laparoscopic lavage only. What about if you have the skills to do a laparoscopic resection? Well, yes, indeed, and this is becoming relatively mainstream now, certainly in the expert centres. And it may be that if we do a keyhole resection, then it may be, that the Hartmann's reversal will be easier, because there'll be fewer adhesions in the longer term. Relatively small case series and a conversion rate of up to a fifth or so, but a higher reversal rate when you look at these series. And the largest series of 66 patients showing that the leak rate was relatively low, and quite a lot of patients had a primary anastomosis. So again, food for thought, and not for everybody, but certainly something to consider. If you have a really sick patient, this is the patient who is septic, who has fecal peritonitis, then the approach which came out of the trauma centres of damage control, that is damage limitation surgery, may be appropriate. And I've used this on a number of occasions for this type of patient, and I think it works well. So this is a short, quick operation, no longer than an hour or 90 minutes, where source control is achieved. And that may be just by packing off or resecting and leaving the ends inside, using a temporary closure for the abdomen, and then moving the patient to the intensive care unit to correct the physiology over 48 hours prior to returning to theatre to do your definitive operation in slower time, raising the colostomy, or indeed joining the patient up, and then closing the abdomen. And I think that there are certain cases for whom this is entirely appropriate. So I said I'd just touch on the fistula side of things. There are 3 main diverticular associated fistulae that you will see. There are others, but these are the 3 main ones. And the colovesical fistula to the bladder, colovaginal. Colovaginal I won't talk about. These are mostly in patients who've had a hysterectomy, and the sigmoid latches onto the scar at the top of the vagina and then perforates through, and it's pretty unpleasant for the patient. And the colocutaneous fistula. And the colocutaneous fistula mostly follows drainage of abscess that we've been talking about. And here is a gentleman that I looked after, and you can see the coronal section here. The diverticular segment has literally exploded out through the sciatic notch. Here it is here on the left-hand side. There's gas and pus within the tissues. And this was drained, and here he is in lithotomy position. having a washout and prior to raising a colostomy. And you can see that a fistula on his buttock was the consequence of drainage. And that's usually why those fistulae form. The colovesical fistula we see very regularly. These patients present with pneumaturia. That's gas in the urine, usually at the end of the stream. Fecal urea and bits of sweet corn and various bits in the bladder in the fecal stream. The CT pathognomonic feature is gas in the bladder, provided the patient hasn't been catheterized, of course, but in the absence of that, you would see gas in the bladder. And cystoscopy, very useful to look at the fistula site itself. And mostly these patients require an operation. If they're not fit enough, then they may just require long-term antibiotics or an upstream colostomy, or a combination of those things. If you do have fistulating disease, and indeed if you've had complicated diverticular disease from which you've recovered, you should evaluate the colon further to exclude malignancy. This is a patient of mine from a couple of weeks ago, only 54 years old, who presented with a classical colovesical fistula, no previous trouble, and here is his sigmoid diverticular disease. Here is his sigmoid cancer with the fistula into the bladder, and here, sadly, is his liver metastasis. And so you must make sure that you're dealing with the right pathology, because that will determine what you do next. Colovesical fistulae are predominantly diverticular disease, about 3/4 of cases, and about 20% or so are malignant, and the other few are inflammatory bowel disease mostly. So that's about it. Just to summarize a few of those issues that I've discussed, despite its common presentation, the etiology and risk factors are still a bit uncertain with diverticular disease. The clinical course, as you've seen, is a bit unpredictable, I'm afraid. Aggressive conservative treatment is what should be employed as far as possible. And we're a bit uncertain over who needs surgery. And we know that these are a high-risk group of patients. Laparoscopic lavage has generally proven to be quite disappointing. And if you do need to do an operation for these patients, you should be resecting the pathology. Okay, thank you.
Well, thank you very much, Richard. I really, really appreciate that, as I'm sure all our listeners did as well. Just fantastic, and an awful lot of information was dispensed there, but it's okay because it will all be up on the website, and everybody can look at the slides in their own time. I'm just going to, a couple of questions, Richard, just from the beginning. Regarding complications of diverticulitis, the inflammation of the diverticulum, what would you say is your most common complication that you're likely to see? And do the complications always have to involve an episode of diverticulitis, or does diverticular disease, just the symptomatic diverticuli without any inflammation, can they cause problems and complications as well?
Yeah. Okay. So there's a few questions there, aren't there?
There are.
This question of diverticular disease, I mean, it's, as its name implies, it is a dis-ease. There are symptoms that are troubling the patient. Now, there's a tendency, as you know, to label all diverticular-associated pain, to label it diverticulitis. And we use antibiotics willy-nilly. There's a huge amount of antibiotics used in general practice. And it might be surprising to many out there that even if you resect a segment of diverticular disease, the patients may still experience left iliac fossa pain. It's quite bizarre, but we do know that there is something known as visceral hypersensitivity, which doesn't necessarily imply diverticulitis. And I think that's why early imaging is really important for these patients. put that in context with your CRP, your white count, to determine whether you're dealing with an inflammatory problem or simply pain arising from diverticulosis. And they're quite separate patients. As far as what's the most common complication of diverticulitis, I guess it's frequent admission, actually, and frequent referral, and a failure to manage patients' expectations. I'd say, you know as well as I do, that a lot of these patients come through, and it's explaining what diverticular pain is, what diverticulitis is, and the fact that, you know, they may have pain and symptoms that are troublesome, but there may not be an awful lot we can do about it.
Yeah. There's a few other questions that are all evolving around the role of radiology in the management of acute diverticulitis. In the young patient that comes in, and I'm talking the 30 to 40-year-old, where you're clinically suspicious for diverticulitis, do they all need a CT? Do they all need a flexi-sig? Supposing the patient was 80, what investigations would you do, first of all, in the acute setting, and then perhaps in the ambulatory follow-up setting?
Yeah. Okay, yes. And as you might expect, the thinking on these things evolves and it changes and goes backwards and forwards, doesn't it? Well, look, the young, as I said earlier, diverticulitis is not exclusive to the elderly. It is more likely to occur. But you have to be very alert, don't you? You have to realize that, that there are patients who are young. I've seen it in their 20s, who may have this problem. And for the sake of radiation exposure, for the sake of achieving a diagnosis, there is nothing better than a CT scan. And we've all seen patients in their 20s who have a sigmoid cancer as well. And I think one has to be very, very careful. There are ways of reducing radiation exposure. You speak to your radiologist, and it's, you know, similarly in appendicitis. If you want to diagnose appendicitis, you can have a low exposure CT scan specifically asking that question. Now, in the elderly, you may be looking at other diagnoses, and it may be more important to have a CT thorax, a CT abdomen, and a much wider exposure, and less risky for the elderly. But if you want to ask your radiologist a specific question, is this sigmoid diverticulitis, you can reduce the exposure. What about the follow-up? I think you're implying, should we be colonoscoping all patients? Yeah. The answer to that is no. I think there needs to be, certainly for the younger patient, an evaluation of the colon. Now, I used my words carefully when I presented. Clearly, if there are red flag symptoms, rectal bleeding, mucus discharge, weight loss, and so on, then you need to go ahead and evaluate properly. Bearing in mind that diverticular disease, this is another talk, doesn't really cause rectal bleeding unless it's catastrophic bleeding. It doesn't usually cause a little bit of bleeding. So if you've got somebody with bleeding, you probably need to follow up with some kind of endoscopic examination, or indeed with a virtual colonoscopy, depending on the fitness of the patient. Now, the radiologists in my hospital, and indeed the endoscopists, would prefer not to go ahead and do an endoscopy, certainly within 6 to 8 weeks. And they would prefer to do a cross-sectional examination in the first instance. They're concerned about flaring things up. So you have to have a time lag. Now, in the 80-year-old, who might have had recurrent episodes of diverticular disease, no, I don't think you need to go ahead and be colonoscoping all those patients. CT virtual colonoscopy is, of course, superb. Very, very good indeed. And most pathology will be picked up. You've got to bear in mind the risk of a colonoscopy and its preparation in an elderly person, and weigh up those risks and decide what's sensible at the end of the day. But we're also realizing that uncomplicated diverticulitis patients are much less likely to have a malignancy associated. So they're much less likely to need to have endoscopic evaluation. In the complicated disease, i.e. the Hinchey 2+, they're more likely to have a malignancy for some reason. And that's been borne out in various trials. So if you're going to choose a group to investigate, it should be the more complex group once they've settled down from the acute episode. Does that answer that?
That's absolutely fantastic, and I appreciate that we've pushed on, but I thought it was important to get a detailed answer there. It's absolutely fantastic, Richard. Look, I'm gonna thank you, Richard, on behalf of the college and on behalf of all the listeners. I just remind everybody on the 7th of May, Principles of Stoma Formation and Management by Stephen Boyce, fantastic speaker. Some of you may have already heard him talk in a previous lecture. Richard, I hope desperately to see you back here again.
Thank you.
Take care, everybody. Wish you well.
Thanks, Charles.
Cheers.